Hello, and welcome to this Ask the Expert session. My name is Dr. Matthew Giannetti. I am the Associate Director of the Brigham and Women's Hospital Mastocytosis Center in Boston, Massachusetts. In a recent program titled Answering the Call in Non-Advanced Systemic Mastocytosis, Targeted Approaches to Patient Management, we offered learners the opportunity to ask our experts some clinical questions that came up while they were viewing the activity. Today, I will be providing answers to those questions submitted by learners. So this is a good question. It's true that several patients, numbers vary, but between 10 and 15% of patients with systemic mastocytosis may actually have a normal serum tryptase. So therefore, clinical suspicion is very important in the diagnosis. In particular, presentations that would cause me to consider the diagnosis would be those with hypotensive syncope or anaphylaxis with hypotensive syncope following a hymenopterous sting. And in these cases, if the baseline serum tryptase is normal, the best next diagnostic steps would be to check for the KIT mutation, KIT D816V, in peripheral blood, or go directly to a bone marrow biopsy depending on the clinical symptoms. I do think the important takeaway here, though, is a significant proportion of patients with systemic mastocytosis may have a normal baseline serum tryptase. So yeah, this dovetails with the previous question. Absolutely, you should consider indolent systemic mastocytosis in patients with severe anaphylaxis from an insect sting. So classically, when I'm referring to insects, generally it refers to fire ants in parts of the southern United States. We don't have much of them in Boston here. And more typically, hymenopterous, so hornets, yellow hornet, white hornets, yellow jackets, wasps, and honeybees. In patients with severe anaphylaxis from stinging insects, even in the presence of a normal tryptase, I typically will check for a KIT D816V mutation, and in patients with other ongoing symptoms, it may also prompt a bone marrow biopsy. Yeah, so this is a great question. Avapritinib has been game-changing for many patients with severe ongoing symptoms. So in those with indolent systemic mastocytosis, I generally prefer using it in addition to some of the more typical and safe oral antihistamines. In the clinical trials, the Pioneer study, which was the major study utilized for FDA approval of avapritinib, patients needed to be on two best standard care medications. So most typically this was cetirizine and famotidine. In some patients, cetirizine and montelukast. Several patients were on omalizumab. But in general, my preference is to try 2 or 3 of these initial first-line medications, and if not well controlled, then I bring the patient in to have a discussion about risks and benefits of avapritinib and to discuss specifically how that may fit into their care plan. So this is a big question, and there's kind of a lot to dissect here. So first, I think it's really important to talk about the prevalence in the population of hereditary alpha-tryptasemia and how that relates to systemic mastocytosis. So first off, we know about 5 to 7% of the United States patients in the United States have hereditary alpha-tryptasemia. So this is a very common genetic trait. Second, we know that systemic mastocytosis is very rare, less than 200,000 in the United States, as it's classified as an orphan disease. Interestingly, in the population of systemic mastocytosis, those patients are much more likely to have HAT. So it would be correct to say if you have mastocytosis, you're more likely to have alpha-tryptasemia, but not vice versa. Second, moving on to diagnosis, and actually one other question in here about progression to systemic mastocytosis. I think the progression question is important as well. So those with hereditary alpha-tryptasemia do not progress to systemic mastocytosis. There's not really been any defined case series or literature showing that those progress. And generally, in my book, if the tryptase is elevated and we have a good reason for it, alpha-tryptasemia, assuming you've done a sufficient job of excluding systemic mastocytosis, there is no progression. You have alpha-tryptasemia, you will continue to have alpha-tryptasemia. And that's actually very important. The initial first part of the question, so how do you distinguish alpha tryptasemia from non-advanced systemic mastocytosis? This is tricky, right? So both diseases often will present with an elevated baseline serum tryptase. Generally, we think of that as greater than 8 nanograms per milliliter. In general, those with mastocytosis tend to have more symptoms of mast cell activation. So, one, they have cutaneous lesions. You don't see those in alpha tryptasemia, fixed maculopapular cutaneous mastocytosis lesions. Two, they tend to have a lot more flushing, urticaria, and flaring of their cutaneous lesions in mastocytosis. And then finally, gastrointestinal symptoms and bone manifestations appear to be more common in systemic mastocytosis. I would say that alpha tryptasemia, we don't really have good diagnostic literature showing that there's a specific symptom constellation in alpha tryptasemia. I think it's very much under definition currently. So I would say if there is at all a clinical suspicion for systemic mastocytosis, it's really important to formally rule in or rule out that diagnosis. At minimum, that's going to include D816V in peripheral blood. And depending on the situation, moving forward with a formal bone marrow biopsy is important as well. So again, multi-part answer to that question, but I think the important takeaways here are, one, it is very difficult to distinguish alpha tryptasemia from systemic mastocytosis, so a very good diagnostic workup is critical. And two, patients with alpha tryptasemia are not likely to progress to systemic mastocytosis. I generally think them as separate diseases, although many patients with systemic mastocytosis do also have alpha tryptasemia. Yeah, the workup for children is a little bit different. This is a good question, maybe outside the bounds of this topic in general. Kids have anaphylaxis for a lot different reasons in general than adults do. So many of us as practicing allergists treat many children with food allergies. That's the most common reason for children to have anaphylaxis. The workup and evaluation is largely similar for the initial stages. So most importantly for children, they generally have cutaneous mastocytosis, and so a really good skin examination is critical in children with anaphylaxis where you're having some suspicion for mast cell disorder. The next steps are moving on to laboratory, so looking at that baseline serum tryptase and checking for a KIT D816V mutation, both of which can be diagnostic for mastocytosis. And then the other really important thing to remember here is children much more often have isolated cutaneous mastocytosis as opposed to systemic mastocytosis. So I think the specifics of this are a little bit outside the bounds, but in general, the workup for both kids and adults with systemic mastocytosis or for mastocytosis are quite similar. Thank you for your time today. I hope you found this information helpful. Please subscribe to Exchange CME's YouTube channel and check back regularly for updates on systemic mastocytosis.